Okay, so for our first test for lumbar radiculopathy, what we're going to do is the straight leg raise for the sciatic nerve. So what we're going to do is we're going to raise our patient's leg into hip flexion up to about 80 or 90 degrees, and we are going to dorsiflex the foot. Now, do you have any numbness or tingling?
No.
No? Okay, perfect. Okay, then this would be a negative test. For our second test for lumbar radiculopathy, what we're going to do is the slump test. So what I want you to do is slouch down into bat posture and then tuck your chin down to your neck. Perfect. All right, and I'm going to extend your knee and dorsiflex your toes. Now, do you have any numbness or tingling?
No.
No? All right, good. Stay in that position. Let me check your other leg. Any numbness or tingling?
No.
No? Okay, good. Then this test would be a negative. For lumbar radiculopathy, both of our tests have good diagnostic utility. The straight leg raise test has both good sensitivity and specificity, and the slump test has good sensitivity, however it does have weaker specificity. Okay, so for our first test for hip osteoarthritis, what we're going to do is the scour test. So I'm going to put my patient into 90 degrees of hip flexion and 90 degrees of knee flexion. I'm going to apply an axial load down into the acetabulum and then internally and externally rotate. And what we're looking for is any clicking or catching and any mechanical symptoms, and we don't have any of that, so this test would be a negative. Okay, so for our second hip osteoarthritis test, what we're going to do is the Faber test. So we're going to take the uninvolved foot, we're going to lay it across the uninvolved, just above the uninvolved knee. We're going to then push down on the knee while applying pressure to the hips. What we're looking for is if there's any pain in the hips. Do you have any pain?
No.
No? Okay. Then this would be a negative test.
For hip osteoarthritis, both the Faber test and the Scour test have pretty good sensitivity, which means that they are good for ruling things out. However, neither had particularly good specificity, which means they can't really rule things in.
Okay, so for our first meniscus test, what we're going to do is the McMurray test. So to do that, we're going to put our patient into full hip flexion and knee flexion. So we're going to look at the medial meniscus first. So we're going to
Externally rotate.
and apply a valgus force to the knee as we go through extension, looking for mechanical symptoms. Then to do the lateral meniscus, we're going to go back into full flexion for the knee and hip, provide internal rotation and a varus force as we extend, again looking for mechanical symptoms. And we didn't have any, so that would be a negative test. For our second meniscus test, we are going to do the Apley test. So I'm going to put my patient's knee flexed to 90 degrees. I'm going to grab their foot here and apply an axial load down into it, and I'm going to internally and externally rotate their foot. And I'm looking for pain or mechanical symptoms. So do you have any pain with this motion?
No.
Okay, any clicking or popping?
No.
Good. This would be a negative test.
For meniscus tears, the McMurray test has both good specificity and sensitivity, which means that it is good at both ruling things in and out. The Apley test, however, on the other hand, mainly has high specificity, which means that it is only really good at ruling things in.
Okay, so for our first PCL tear test, we are going to do the Godfrey SAG test. So what I'm going to do is I'm going to have my patient into 90-90 for the hip and knee, and then I'm going to ask they just relax their legs. And what I'm doing is I'm looking for the tibial tuberosity of each leg to see if one is sagged below the other. So they are at the same level, so this would be a negative test. All right, for our second PCL tear test, we are going to do the posterior drawer test. So what I'm going to have my patient do is flex their hip and knee just a little bit, and then I'm going to ask them to make sure their hamstrings are relaxed, and I'm going to apply a load right up at the tibial tuberosity, and I'm looking for posterior movement of the tibia. And we don't have any laxity there, so this would be a negative test.
For a PCL tear, both the posterior drawer test and the SAG test have very good sensitivity. However, they have exceptional specificity, meaning that if these tests are positive, we can rule in a PCL tear.
All right, so for our test for a syndesmotic ankle sprain, we're going to do the squeeze test. So I've already confirmed with my patient that she does not have a contusion, a fracture, or compartment syndrome. So what I'm going to do is I'm going to squeeze right here, forcing the fibula and tibia together. And what I'm doing is I'm looking for pain as I continue to squeeze and move down towards the ankle. So do you have any pain?
No.
No? All right, this would be a negative test. All right, so a test for anterior ankle impingement, we are going to do the forced dorsiflexion test. So what I'm going to do is I'm going to take my patient's foot, I'm going to push my thumb in just anterior to the lateral malleolus, and then I'm going to dorsiflex her foot. And what I'm looking here for is pain. So do you have any pain with this movement?
No.
No?
Nope.
Okay, then this would be a negative test. All right, so now we'll be assessing for an Achilles tendon rupture. So we are going to do the Thompson's test. So what we're going to do is we're going to have our patient flex their knee to 90 degrees, and then I'm going to squeeze the middle 1/3 of the calf, and I'm going to be looking for plantar flexion of their foot. And I can see a little bit of plantar flexion, so that means that this test is a negative.
For the ankle, the squeeze test has questionable utility as it doesn't have a listed sensitivity or specificity. However, the forced dorsiflexion and the Thompson test both have very good specificity and sensitivity to them.